Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this Aspen podcast. Let's get started. Welcome to episode 12, season 3 of the Pain Unfiltered podcast. I'm your host, Dr. Patrick Buchanan, and with me is my co-host, Dr. Timothy Deere. Tim, how you doing as we wrap up the last episode of season 3?
You know, Patrick, I'm doing great. I recorded a little video with some of our young innovators this week. See you in Miami. The motto of the video, looking at the July 16th and 19th meeting in South Beach. So it was really a lot of fun, and I'm doing great. Thank you. How are you doing?
I'm doing great too. Yeah, looking for that meeting. It seems like every year it gets bigger and better. So looking forward to, like you said, especially the young innovators and seeing what they have to show for, and also the new technology as every year just keeps growing and growing. So we want to thank our sponsors who have supported us all season long: Mainstay Medical, SPR, Spinal Simplicity, Biotronic, Limbus Health, and last but not least, Saluda Medical. And that's an easy segue into introducing our guests today, who are two of the top experts in closed-loop stimulation. Thanks for joining us, Dr. Jason Pope and Dr. Jonathan Goree. How you guys doing?
We're good. Thanks for having us.
Yeah, doing well.
Fantastic. So, Jason, we'll start with you first. Just give a brief background about yourself, even though this is your record third time on the podcast. And we'll go dive into a little bit of Saluda.
Well, thanks, Patrick. So I'm Dr. Jason Pope. I'm a simple country doctor from Santa Rosa, California. Had some time in sunny West Virginia. I'm an anesthesiologist, and I would say that I've committed a lot of my time in my professional life on education and on neuromodulation.
That's awesome. Why don't you give a brief snapshot into what the state of neuromodulation and spinal cord stimulation right now, and kind of how closed loop fits and maybe solves some of this?
Well, so I'm a proponent of spinal cord stimulation. It's been around for 60 years, and just like your smartphone or your television, it's getting better and better and better. And for the first 50 years, we're really focused on hardware. We were focused on Holsheimer's theory. We were focused on, tripole arrays. And then we got into waveforms and trying to move away from maybe trying to answer the wrong question of consequences associated with overstimulation. And then within the last 10 years, and I think I'd like to frame the audience by just describing that physiologic closed-loop controlled therapy, although being commercially available since October of 22, has been around for over a decade in regards to the innovation and the science surrounding making it commercially available. As we all know, when there's an innovation cycle in the space, it requires investigation. It requires an IDE study, which is an investigational device exemption study. And when we think about how physiologic closed-loop controlled therapy has come into market, it required that. And when we look at that, and I know we talked about it on the podcast last time, it is, I think, a fundamental value add to our space. So we've never seen a study that's been prospectively acquired, double-blinded, multi-center, self-selected crossover with a 36-month follow-up. And that's durable. I mean, when we think about spinal cord stimulation, we always used to think about the trial to perm conversion. And we would define success with a trial as whether someone converted to a permanent therapy. And I think now, when we have the ability to leverage a physiologic closed-loop controlled therapy, I think, in my opinion, all trials are successful because you're really trying to determine whether someone responds to electricity or doesn't respond to electricity. And I think when we look at our space, it's been plagued to some degree with durability challenges. And I think it may come down to largely having the ability to measure what you're doing to the spinal cord.
No, that opens a great window of discussion, Jason. Thank you for that introduction. And, able to measure. And Jonathan, I think I was first exposed to the sensing and the closed loop back in 2011 when I went to Australia to visit John Parker and his colleagues. And then I saw the Evoke study come to fruition. What does measuring on every pulse mean? What does adjusting up or down mean? What really is the important factors based on all that data and that physiology that we should think about?
Yeah, no, thanks for that question. I think this is the first time that we really can objectify electroceuticals and electrify how we dose electricity. So I think we have to start with ECAP, because that's what makes this possible. And ECAP and its Evoke compound action potential, it's the ability to measure the reaction of the spinal cord. So we've always titrated the action, which is the voltage that we send to the dorsal columns. But now we understand and can measure for the first time how the spinal cord reacts to that electricity. And when I think about the best analogy is we've all given gabapentin, and we all can say this is a 300 milligram tablet. That's the action. But if we were able to measure how many calcium channels we affected, that would be the reaction. So we're able to now, for the first time, understand how the electricity is affecting the patient. And since we have that titratable ECAP, or that measurable ECAP, we can create a dose response curve, and we can understand how every patient responds to electricity. And we now know through studies that every single patient responds to electricity differently. And so if we're able to anchor our therapy on that reaction, on how the cord reacts, and we're able to measure it, and we're able to titrate around it, then we can vary the voltage or the current pulse by pulse to ensure that the reaction or the cord's action or the cord's response to electricity is the same over time, which gives us consistent therapy. And as Jason discussed, one of the challenges in our space now is durability of therapy. And if we ensure that a patient on day one, that their cord reacts to the therapy in the same exact way that their cord reacts 3 years from now, then we can fix that durability problem.
That's great. That's a great explanation, Jonathan. I'll swing this over to Jason for the next question. And we talk about now we can capture data, and now we have all these data points. How does that change your clinical practice?
Well, so it's funny. I've been in the space long enough where we say that the currency of our space is data. And I think I'm getting old enough now where I'm starting to disagree a little bit. I think that data is really critical, and I think we are evidence-based at heart, and I think we try to do the right thing altruistically for our patients, and we want to make sure that we're putting our best foot forward with developing a differential diagnosis, coming up with a plan where we talk about risk, benefits, side effects, alternatives, and then we move forward. And there's been a lot of surveys in our space looking at the importance of data versus the importance of representative support or the importance of accessibility. And I think it's kind of a combination of those things. But all that being said, we wouldn't have spinal cord stimulation for nearly 60 years without some data. And I think we've had some landmark studies that have kind of moved us in the direction. We had Kumar, we had the randomized study looking at previous back surgery versus spinal cord stimulation. We had studies looking at spinal cord stimulation versus conventional medical management. We have data that's coming out looking for non-surgical low back pain. We have data coming out looking at spinal cord stimulation to treat both back and leg. And then we have also had all these data points coming out looking at CRPS, cervical problems. And what's interesting is when you look at all of that data, it's starting to all look kind of the same in terms of about 80% of people getting at least 50% relief and about 60% of people getting 80% relief or more. And the question that I started asking myself, and even at NANS when we heard some data presentation on neuromodulation there, was what's the quality of it? You know, so it does a retrospective study. Should that be weighted differently than a prospective multi-center IDE study? And obviously, I think the answer is yes to all of us. How we qualify that in our practice is probably fundamentally based on the physician. I try to practice evidence-based medicine as much as possible, and I try to pick people within my practice that meet the inclusion criteria of those studies. And thankfully, in the circumstance of physiologic closed-loop controlled therapy, I'd say arguably we have the best, or there is one of the best studies that we've ever accomplished in our space. But that was for back and leg, right? And so we say, well, let's expand this out. So we did a study, which was the second IDE study, which was the ECAPS study, when we were looking at other patient populations. And, you know, we were treating cervical stuff, we were treating peripheral neuropathy, we were treating a variety of different things. And consistently, what we ran into was this concept of ECAP measurement, which is what Jonathan described, so the evoked compound action potential, and then anchoring a dose to that with the device's job of maintaining that dose accurately and consistently over time, adjusting. You know, I'm simple, so I think about it in terms of volume. So it's adjusting the volume up and down to really just maintain a neural activation. And we see that where you place the leads is different. All right. So if you place leads in the cervical spine versus the thoracic spine, the dose that's required for therapeutic benefit is different. We see disease-specific dosing. And then I think where we're seeing differences is the predictability of, or the prognostic utility of using a physiologic closed-loop controlled therapy, predicting success during the trial. And we published on day 0 to day 7. During this last meeting, we presented it at day 0 to 12 months. And I think we're able now to say, what you see is what you get, with a higher degree of confidence than we've ever had before. And largely it's because we're stimulating the same way during the trial that we are during the more permanent phase of the procedure. We're measuring an ECAP, we're anchoring a dose, and then we're going to maintain that dose. And that's something we haven't seen in our space. And to be candid, when we look at spinal cord stimulation across other paradigms, oftentimes people throw electricity at folks during the trial, and then they say, well, there's maybe a wash in or a wash out or some issue, and then we're going to kind of titrate them to effect in the permanent phase, knowing that you're not really comparing apples to apples. It's fundamentally different. And so I think the most powerful thing I've seen in my practice, and the most powerful thing I've seen with the data that we've helped generate with this physiologic closed-loop controlled therapy, is the prognostic utility of trialing.
Yeah, that was a great answer. Jonathan, I was going to ask you about cervical versus thoracic, but I think Jason covered that quite well. So I'm going to change it up a little bit here and ask you a different question. So a lot of people who go through their fellowship, go through the rehabilitation practice, I don't know if they even understand where an ECAP is. And then how does that relate to what Jason just said about the dose in the cervical spine versus thoracic? And then how do we know what dose to give someone on the ECAP to make it accurate and go up and down with every beat? So I'm just going to break it down here to the fundamentals. Can you explain kind of that for the viewer who may have done a fellowship somewhere where they weren't exposed to this type of therapy?
Yeah, of course. And Jason jumped out and said he was a small town country doctor. I think he stole that from all of us. I think all of us would say the same thing. But, I explain this to patients all the time, and why I think it's what they should choose. And really, for me, an evoked compound action potential is a measure of the extracellular voltage of the dorsal columns. And action potential are all or one phenomena. If we go back to medical school, right? You can't be either you're having an action potential or you're not. But if you have a million neurons that are bunched together, then as you increase the electricity you deliver to that bunch of neurons, then more neurons are going to get excited. And as more neurons get excited, you're going to have an increase of sodium rushing into the cells at certain points. You're going to get rushes of potassium in and out of cells at certain points. And so when you measure that change in voltage, as more and more neurons reach action potential at the same time because they're reacting to that initial stimulus, then that difference is the ECAP. So that allows us for the first time to understand, it's really a surrogate for what percentage of the dorsal columns we're exciting at any given time. And so if we know that number and we can match that to subjective pain relief, which is what I would say is the first generation of the system, then once we get a patient to the point where they get maximum pain relief, we can keep them there, because we can say that we need to excite 55% of your dorsal columns to get you pain relief. And if we excite more, you're going to be overly excited. If we excite less, then you're not going to get enough electricity. We can keep it there over time for years. And so taking that a step further, if we now have a titratable measure to understand how the cord responds to electricity, we can create dose response curves for every single patient. So we can slowly increase the amount of electricity we're delivering to the cord, and we can understand how each individual patient responds. And then we can determine what their ECAP measurement is to get them maximal pain relief. Now, taking that a step even further, if we look back at all the patients who were in the EVOKE study and in multiple real-world studies, we determined this concept called maximal analgesic effect. So if you look at all those patients and you look at the point that they actually were doing the best, where they had the best outcome, and you look at all of their dose response curves, even though they all look different, we saw a trend. And the trend is that there's a ratio called a dose ratio that if you apply to an individual unique dose response curve, you can predict what ECAP dose they need to get pain relief. So we can take the subjective measurements of all those people that we studied in the past, and we all know that they did well based off the study. We can now predict objectively what a patient's best subjective outcome is going to be. And that's something we've never been able to do before in our space. And as we are now being prospective in our clinics and doing this anecdotally, but also studying it, we can see that it works. And that when patients get that objective dose, that predicted dose, that they actually do get subjective pain relief and maximal pain relief and satisfaction.
Go ahead, Jason.
Yeah, I'll jump in here and say that, Jonathan, that was really well put. When we try to break it down to the simplest terms, we can guarantee neural activation. And we can guarantee that with neural activation, where we have this evoked compound action potential, and then we look retrospectively at all the data to say what is the volume of tissue that's required. You can think of it that way, where people will have an opportunity for therapeutic success. And that's this concept of maximal analgesic efficacy. And what was beautiful about this is that when we were going along in these studies, we didn't know anything about a maximal analgesic efficacy. We just would turn the people up. We would identify where they were most helped. And then retrospectively, we looked back and said, wow, this is the dose ratio that people are getting. It's between 1.2 and 1.4, and it's a little lower in the cervical spine. And it seems to be a little lower in some disease states like CRPS. But what Jonathan was describing is that the application of electricity is unique for each individual person because everyone's dose response curve is different, but how that dose response curve is applied with this maximal analgesic efficacy dose ratio, the ratio is consistent, but the dose is different. if that makes sense, or the amount of activation is different. So it's kind of standardizing things, kind of like an INR, if you want to think about it that way, right? In terms of anticoagulation. And when we look at, again, for those of you that have heard me talk before, my father is a scientist and I have to put up with him at the dinner table, and my brother's a scientist and I have to put up with him at the dinner table. And we talk about, you have to have evidence generation, and a flash in the pan success is once, but then you have to have some confidence by reproducing it, which is the scientific method. And so we can see that the way that the MAE strategy was arrived at was one where it was validated multiple times during the application of this physiologic closed loop controlled therapy.
So, Jason, my dad was a coal miner, not a scientist. So I'll pull out some of that for you two guys and have you answer this. So, there's the studies you've described, they've fantastic data. Certainly have been honored to be involved in some of that work. But the old saying in the coal mines is, what have you done for me lately, buddy? So the question is going to be for both of you, what's next? What next evidence are we going to be looking for to further the closed loop therapy, to make it even better, to make it actually have even more support in the literature? So Jonathan, you want to take that first and then come back to Jason?
Yeah, I'll first comment by saying that I've met Jason's brother and he really is a scientist, in case anyone was wondering. But to get back to Tim's question, I think we always do a good job of creating data in a controlled environment. Saluda has already also published a real world IDE study in the ECAPS study, but I think we will continue to collect real world data and also collect anecdotal data as we all are actually putting this car on the road, right? And so I'll talk about an experience I had with a patient last week that I think is important, and then I'll let Jason, whose brother's a scientist, talk a little more about the science. But I saw a patient who I trialed about 9 months ago, and he had a great outcome, 85% relief. We assumed it would be a home run. We implanted him, and that patient actually was telling us that he was not having the same result in his implant that he was having in his truck. And when we brought him in and we interrogated the system, we were able to use this data that we generated through this MAE study to show the patient that he was running his stimulator at a lower dose than he was during his trial, and at a lower dose than what we would predict based on all the patients that have done well, that he would get maximal benefit from. And so I was able to look him in the eye and say, we need to turn your stimulator up. And that was based on actual data. That wasn't based on my experience, when I got patients, I turn it up or I turn it down, or a rep saying that, now I changed this program when things are failing. I was able to objectively look at his device and say, you're at this dose. You need to be at this dose. You're taking 400 milligrams. If you want to do better, you got to take 500 milligrams. And we turned him up and we told him to put his remote away for 2 weeks. And he came back and followed up in our practice. And he was like, I'm back to where I was at the trial. Because we actually are making decisions on objective data. We're being doctors again. I would say the second piece is the idea of EVA, which we haven't touched on yet, which is basically a device that creates these dose response curves for us and also filters out the noise of the spinal cord and does it efficiently, right? And so we've now published that it does that in less than 10 minutes. And so, we are collecting a lot of data, and collecting a lot of data is great, but in the environment where we're seeing patients and we're doing all these things, we need to be able to do it efficiently, and we need to be able to make decisions based off that data if we're collecting it in real time. And I think what we're going to show is the benefit of doing all those things over the next few years.
No, the other thing about that, Jason, I'll let you answer, but the other thing about that, that you point out, which I like a lot, is if you go back to the old Avalon study, for those listening, that was a study done in Australia early on. And I remember it was presented in a very long meeting, about a 3-hour meeting, which took way too long with too many slides back a few years ago in Vegas. But at 3 years, they were doing better than they were at 1 year. And I think some of that goes back to learning the dose. And you're better now at learning the dose than you were back then. And you saw, we usually see fall off over 3 years. You actually saw continued improvement over 3 years. I was so fascinated by that result. And I think it came back to a very rudimentary ability to learn the dose. Now you're learning it through EVA and other methods. So now you're learning the dose even much more effectively. So love that answer, Jonathan. Jason, you want to give an answer to that as well here?
Yeah, I'll highlight also by just saying that we now have the ability to use physiologic objective data to guide our decision making on how to manage and employ these devices. We've never had an opportunity to even have the discussion about really a physiologic dose response curve. We've never had the ability to talk about dosing of the spinal cord. Now we have the capacity to do that. And again, retrospectively, that's been validated. Now we can kind of tell you where the ballpark is on where you should be in terms of, call it volume of tissue or call it the volume of the device in terms of delivering the chance for therapeutic benefit. And, we talk about these neural metrics, like what are neural metrics? It's accuracy, it's the dose, and it's utilization of the therapy. And we've never had the ability to do that before. So when I look at the next clinical study to help describe this, is it a registry study where we're looking at maybe real world use of looking at EVA in the real world? Is it applying what we know? And I'll back up a step and say the experience that we've all had with spinal cord stimulation is exactly what Jonathan talked about, right? People have awesome relief during the trial, and then it kind of falls off 3 months, 6 months, 12 months, 24 months. And the question really is why? And I think if I'm reasoning this, I think that electricity works on the spinal cord. And I think a lot of ways probably work on the spinal cord. The challenge is keeping it there. So when people come to your practice and they're not doing well, you get them programmed. By the time they leave your office, they feel great. But when they come back 2 weeks later, they say, well, it worked well for a couple of days and then it kind of fell off again. And that, in my opinion, I think is related to the consistency of neural activating. And that's essentially what a physiologic closed loop controlled therapy does. So if we apply the opportunity not to salvage, but to rescue people that are having challenges with maintaining neural activation, I think there's a unique opportunity there because we can, again, confidently say, and people may have said, they're responding to electricity, but we should do a study to maybe look at how to strategize on rescuing people from the inconsistency of neural dosing.
I think you touched on a really good point there when it comes to why STEM doesn't work in the long term, because when patients don't have consistency or when they have inconsistency, that's when you start to tinker, right? When it's like, I feel great when I'm laying in bed, but then the minute I get up to brush my teeth, my pain relief drops. So what are we taught to do? We're taught to go get our remote and then play with it. And then as we go through the day, now we don't feel good when we lay down because we change the settings. And so we get into this, patients get into this pattern where they're constantly changing their settings and they end up completely in a different place than where they were when they were sitting in our office. And I think the main point is what we're presenting for the first time is objective, basically being able to choose an objective dose and titrate to it. But I would say what that allows us to do is to provide consistent therapy so that pain relief is consistent over time. So patients don't need to spend as much time going up and down and tinkering and changing things because they have a change in their outcome due to positioning or for whatever reason.
Yeah, and I'll jump in again and say that there's never been a time in my career where I've had people that we've used electricity therapeutically for, say, back and legs. And then they'll come in and they may have had a previous neck surgery and they say, well, can you do what you did up here or, down here, up here, can you do that? And then we talk about MRI conditionality and having 2 devices and all the other nuance associated with that. But over the last 2 years, I've employed 2 systems, treating 2 different regions of the body, which something I haven't really done before. So does that speak to consistent of neural dosing? Potentially, right? I mean, I think that when people get a really good consistent outcome and they misplace their programmer because they're not adjusting it up and down 1,000 different times, I think it kind of opens the world up to again, leveraging the data to help people consistently and globally.
Hey, you guys, Jonathan and Jason, brought up great points. How EVA and closed loop has impacted my practice as well. EVA empowers the patient to find that sweet spot in their dosing and pain relief. And Jonathan, I've had several patients, just like you mentioned, there's, they come in the room and you see that they're completely underdosed, and you can tell them, hey, look, this is the dose we need to get at. Let's work it there. And, they do great with that. So I think a lot of physicians using this closed loop can relate to that. We'll send off with one last question, unless you have any more, Tim, as we wrap up this episode. So, in the next 5-10 years, let's look forward thinking here. Do you think closed loop or some kind of objective measurement in spinal cord stimulation is going to be the standard of care as we move forward here? Jason, we'll start with you, and then Jonathan, and Tim will wrap up with you.
A short answer is yes. I think it's going to really be it's going to need to be the intel inside.
Yeah, okay, I think it's the gold standard. And, if you're able to understand what's happening at the spinal cord, that's better than understanding what's happening at the lead, just straight out. And so I think we need to understand how patients are reacting instead of the electricity we're putting out. And so I think we're just going to improve upon that technology over time.
Well, so my answer, Patrick, is a little bit different. I think, it certainly may be, and I think both my colleagues' answers are quite good. And I think, closed loop, as you've described it to Saluda, and the beat by beat up and down change is definitely going to be fantastic, and we'll have a role. But it's somewhat like if you're making a batch of chili and you put a little extra Tabasco in, there might be the perfect dose for that hotness. But down the road, someone may invent a new chili that's so much better than the old chili, it doesn't even matter how spicy it is. So I don't know if we know what's coming along in the next 5 years. There may be something comes along that's so neural transforming that it changes everything. So I'm going to say I agree with my 2 friends here. Patrick, you're going to get the last word at the moment, but I'm hopeful something comes along that's so amazing that it modifies what we're currently doing with closed loop. And maybe closed loop's part of it, and then there's something else that hits a different cell in the spine and something that changes the perception in the brain. And so I'm not convinced that we're not going to come along with something brand new that we haven't even heard of yet. So I guess that's why we'll have the next season to discuss the new developments as we see them come along.
I love it, Tim. Always trying to play devil's advocate here. Spice it up. Well, I want to thank you guys for joining us, Jonathan, Jason. You did a great job in simplifying what an ECAP is, how closed loop really affects our patients and moving forward. For all those who are listening, if you haven't heard their episode last season, they talked about the differences in closed loop stimulation. Are all closed loops created equal? So I encourage you guys to go back in there, and we're looking forward again to hopefully next season, like Tim said, to discuss the advancements on everything that closed loop has to offer. And I think that's what's so exciting about our space right now. There's every year someone tries to one up the other one, and there's so much great innovation and research to help our patients. Well,
see you in Miami.
That wraps up season 3 of the Pain Unfiltered podcast. Thank you all for joining us.